Today I wanted to talk about managing chickenpox in pregnancy. Whether a patient comes in concerned about potential exposure, but also if they're experiencing symptoms suggestive of varicella. This will hopefully be one of many videos to discuss presentations encountered in primary care, but also contribute to those preparing for the SCA examination. I just wanted to highlight that this video is for educational purposes only, and it's not intended as a substitute for medical advice or treatment. I do encourage all my viewers to check the credibility of any educational resources that they review, and always seek advice or guidance from a medical professional if there are questions or concerns regarding your own health about a medical condition or any symptoms. The key aim of this presentation is to improve the awareness amongst clinicians on the assessment and management of exposure to varicella during pregnancy, particularly since there has been an update surrounding the prescription of post-exposure prophylaxis in 2024. For those preparing for the AKT, the DRCOG, or anyone with an interest in women's health, I do recommend using the Green Top guidelines from the Royal College of Obstetrics and Gynecology. They do provide evidence-based practical tips and advice surrounding a lot of women's health presentations. We'll start off with a bit of background. VZV, or the varicella zoster virus, is the cause of what we know as chickenpox or shingles. The most important thing is to highlight that it is linked to maternal mortality and morbidity, and there is a small association with what's called as fetal varicella syndrome, but these complications all depend on the severity and the timings of the exposure. Now, contact with people with chickenpox can be common, but actually developing varicella zoster virus related infection is actually less common. But we need to know how to address exposure and the management. As explained, the management of the case is based on the level of risk and exposure to chickenpox. But what I would say is one of the most important things to address, because it will determine and change your management, is any past history or exposure to chickenpox or shingles. That includes immunization or vaccinations, but also the timing between the current assessment and the initial contact with the individual that had chickenpox. It's also important to establish if there's any current symptoms, and naturally there's going to be a lot of questions surrounding what is the level of risk currently, how are we going to manage this risk, and what's going to happen next. So it's important to have that information to hand to be able to counsel and address those fears and anxieties surrounding this exposure. Another important consideration is to be aware that chickenpox is contagious, so it might be important to screen for those who are at risk of developing severe infection. That includes people who are pregnant, immunocompromised individuals, and newborn babies or neonates. So in terms of determining what happens next and whether you are in a position to just provide reassurance to a patient, it all depends if the patient is deemed as low or high risk. And it essentially depends on two things: the level of exposure and the level of immunity that a patient has against the virus. Significant exposure depends on the amount of time exposed to an individual with chickenpox, as well as the amount of contact, whether it's face-to-face, being in the same room, direct contact, or chickenpox can be spread by respiratory droplets, so a cough, for example. These are all things that you would have to take into account when making a decision of whether a patient is deemed as low or high risk. An additional thing that you may or may not be aware of is if patients are from tropical or subtropical areas, there should be a low threshold to consider testing for IgG antibody levels. Anyone who has a positive IgG level That's based on the reference range that the lab provides, or if they are able to say that there is sufficient immunity to the virus, then we are able to provide reassurance to the patient because it tells us that the patient themselves have enough antibodies to build an immune response against the infection. However, a discussion with the specialist should be considered if you still feel that the patient is high risk, mainly to ensure that there is a safety plan and follow-up and monitoring for the patient and also for the baby, whether they need to be seen by the fetal medicine clinic, whether an ultrasound needs to occur. These are all things that need to be in the back of your mind, especially when a patient presents with significant exposure to chickenpox or if they actually have the condition themselves. The topic of vaccination might come up, particularly for those individuals who are uncertain if they've had the infection previously. Unfortunately, the vaccine can't be given in pregnancy because of the nature of its contents. It is a live vaccine, which means there's a potential risk of harm to the newborn if given. However, it is safe to breastfeed if the vaccine is planned to be given if the immunity status is still not adequate to provide future protection, in which case, if the vaccine is given postpartum, it is safe to breastfeed. The guidelines surrounding post-exposure prophylaxis to varicella has changed. Previously, varicella zoster immunoglobulin was promoted, but now there's been a shift towards offering oral antiviral treatment. Although the medication itself is not licensed in pregnancy, the current evidence does advise its use based on the benefits being greater than the risks during pregnancy. Now, this is specifically related to post-exposure rather than active infection. So, at any point, if there is a development of a rash, that is suggestive of an active infection, in which case you advise patients to always seek advice from a medical professional to determine the next steps, regardless if post-exposure prophylaxis has been given. Now, the UK HSA has advised for oral antivirals to be given from day 7 to day 14 after the timings of the exposure. So let's say a patient presents one day after the event of exposure, they would actually be given medication a week after the day before. That specifically is for if we are going to be recommending the use of oral antiviral treatment. It is a bit different if immunoglobulins are advised, but the use of varicella zoster immunoglobulin would usually be given if there are contraindications or adverse effects from the use of the antivirals. At that point, a discussion with the specialist would probably help guide your decision making as to what to do next. If a rash develops during pregnancy, you've already given advice to the patient to seek a review with either the GP or a medical professional. Now, if they are seeing you within 24 hours and there is a rash, then there should be a strong consideration to start the patient on acyclovir or oral antiviral treatment. The evidence is particularly strong if the pregnancy has progressed more than 20 weeks gestation. Although the treatment is not licensed in pregnancy, it's important to explain that it's not harmful. You should have the discussion and document the discussion based on the benefits and risks of the treatment, and also think about discussing with a specialist if the patient has presented less than 20 weeks gestation. As highlighted at the beginning of the presentation, varicella can be linked to increased morbidity and mortality. So it's very important to highlight that patients should be aware of any worsening of symptoms, any development of new symptoms, or persistence of their symptoms, particularly if it's going after day 5. If there's any breathing difficulties, any neurological changes, if the rash starts bleeding or is in a high risk area, such as close to the eye, in the ear, then these are all things that would warrant a review in hospital. And as the virus itself is contagious, it's important to counsel patients to avoid contact with other pregnant women, anyone who's immunocompromised, and also babies and neonates, especially if these individuals do not have confirmed evidence of immunity against the virus. So some important practical tips would be to think about how you're able to refer to your local fetal medicine unit, how you can contact your on-call ONG specialist, but also think about how you can provide information to your parents that can support the consultations that you have with them. Always encourage patients to seek medical advice if they're unsure or uncertain about their symptoms and it's causing some form of impact on their day-to-day function. In the case of chickenpox, if a patient presents with a rash, they should be encouraged to seek medical advice to help determine what the next steps are. And as we've already discussed, that might include taking a history, getting a blood test done to check for previous infection or immunity, thinking about post-exposure prophylaxis following your discussions with the specialist, particularly if those are deemed high risk, but also providing information about when to seek medical advice if symptoms are worsening. There is additional information from the college website, as well as patient information leaflets that can be given or sent to patients. It's very good. It does explain things in a very friendly manner. It has a summary of the key things for patients to look out for at the top and beginning of the leaflet, as well as going into a few common question and answers that patients may have surrounding exposure, as well as the active infection of varicella in pregnancy. With regards to following up on reviewing what we've talked about today, both NICE-CKS and the Green Top Guidelines are a good place to start to follow up from this discussion.